Countess of Chester.
Thank you very much. It's really nice to be here. I was driving here this evening and I was thinking, I've been the chief pharmacist at the Countess for 12, 13 years now, and this is the first time I've ever stood up in front of you guys. And I was thinking that's probably going to be one of my regrets about my time at the Countess. So it's not another 12 years before I'm back in front of you talking about something that we can do together going forwards. And it's been really nice to bump into some old friends, Gordon and Stu, I haven't spoken to you yet. And Phil was with me when I was a pre-reg at Boots, I won't say when, but a long time ago. And the big thing then was smart cards. Everyone wanted to have a smart card with all their medicines on that they could carry around, and we could swipe it and see what medicines they were taking and that kind of thing. And it was a long time ago because the internet hadn't been invented even then. So yeah, things fortunately have come on since then. Okay. Yeah, cheers. Oops.
You've broken it.
I've broken it. Yeah, so one of the key things is that, have I missed a slide there? No? Okay. One of the key things then is that we've adopted a lot of technology at the Countess. We've got ward-based automation, we've got dispensary-based automation, we've gone live with e-prescribing, but we're still using the post, Royal Mail, or faxes even to communicate with you guys, and clearly in 2017 that's not really acceptable. And the problem with faxes, of course, is if one wrong number and patient's information can end up in the wrong hands, which is clearly a serious information governance breach, and you know, it's clearly not right for the patient, and it gets us in a lot of trouble as well with the information governance guys. So this new system is going to be really good for us because we can be confident that any information that we transfer out to you will be done so securely, and will protect the patient's information in an appropriate way. So we were really pleased to be able to be one of the pilot sites for electronic transfer of care to pharmacy. And Hassan's already mentioned this. So we're using Farm Outcomes, which I know many of you are familiar with. Some of the other sites are using Refer to Pharmacy, which has been really sort of pushed in sort of the Lancashire hospitals. So when patients move between care settings, there's lots of evidence that this is where problems occur. And it's not just from hospital into the community or vice versa. Often it's from A&E to the medicines admission unit, from there to intensive care and out again. Things can go wrong. Patients step down to intermediate care, to nursing homes, and then back out into their homes. So there's lots of opportunity for things to go wrong, and that's what we want to stop happening by sharing the right information. So there are lots of stats. We like stats, don't we? But key things are, you know, 9 out of 10 patients will come out of hospital on different medicines to the ones they were taking when they came in. 50% of medicines prescribed at discharge will be new. About a third of medicines patients take are stopped during their admission for adverse drug reactions, drug interactions, inefficacy, that kind of thing. 60% of patients have 3 or more medicines changed during their stay. Up to 20% of patients have adverse drug reactions. And there are lots of hospitalizations because of adverse drug reactions post-discharge, and we've published some work around that in tandem with the university. So there's lots of evidence to say why medicines are really important in keeping patients safe. And this is recognised in key documents, so the Pharmaceutical Society's transfer of care document, and also there's nice guidance as well around medicines optimisation to make sure that we protect patients from avoidable harm. So a number of key challenges faced us setting out in this project. So the first was choosing the right provider, and I think the fact that many people were already using Farm Outcomes made it an obvious choice for us. The fact that it was cheaper had nothing to do with it, of course. And then finding resources to do it. So I don't know if any of you have seen in the Chronicle, we've all been tracked in the Countess. We've got our tags that we can be tracked wherever we are in the hospital building. So that's been a massive project, really revolutionising the way that we manage the hospital, and that's been a massive drain on resources from IT. So part of the problem with this project has been getting the right resources behind it at the right time. We've had lots of issues with technology, haven't we? We thought we were ready to go, and then we found a glitch, and then we thought we were ready to go, and have had another glitch. But again, the team's been really good in working through that. And the one thing I'd say about moving to electronic systems is you become more and more of a slave to them. So you rely on glitches not happening in systems. So we found in the past there's been a corruption in our discharge prescription file. We've had to go back and check every single prescription we've released to make sure there aren't any patients exposed to harm because of that. So technology is really important, but you've got to get it absolutely right, otherwise patients are put at risk. Then information governance, this was a much bigger challenge than I think any of us thought it was going to be. Yeah. And again, it's right that we keep patients' information safe and confidential, and don't share information with people who don't need it, because we do have a right to privacy. And then evaluation, that's the next step for us. So what is the referral? It's an automated transfer of information from the hospital. It will notify the pharmacy at admission. So it's not automated as yet. We have to initiate a notification. So if somebody comes in with a multi-compartment compliance aid, for example, then we can start a referral off, because we know when the patient leaves the hospital that they'll need the information coming to you. So we make the referral on the day of admission. Overnight, the information is put into the system, then it comes to you the next day. And then at discharge, then we wrap that up into a kind of package of information for you, and that pulls in all the discharge medicines, all the doses and frequencies and that kind of thing. And then, where necessary, some personalised messages around, you know, there's an unlicensed thing, or we can't put this drug in the compliance aid, or that kind of thing. So that should be quite helpful as well. We do have to get consent from patients to share their information. We've got a protocol around that and a patient information leaflet. Yeah, and I'll show you the process, which is really quick and straightforward. So you'll see how easy it is for us to do it, which is great. So we're going to share information with you about the patient's medicines. We're going to request perhaps some that you might think about doing some follow-up services. So maybe dose titration needs checking, or there's an unlicensed medicine that you might need help sourcing, or that kind of thing. And again, we know that sometimes when we send information to GP practices, those changes aren't initiated, and it's really important that they are. So again, if you've got the discharge prescription, you've got patients coming to you, then you'll have the information you need to say, actually, their ACE inhibitor's changed, or whatever's changed, and you'll see that in future as well. Evidence shows that there's a reduction in readmission rates for patients who have this service. It reduces unnecessary drug waste in dispensing. So again, you hear stories of patients who've been with us for 3 or 4 weeks, and the community pharmacist has done all their monthly compliance aids, and I know from our end of the things, that's a massive waste of resources and time, so we don't want that to happen. And some of our drug misusers as well, you know, it's really helpful for you guys to know that they're in hospital, so that people aren't picking up on their behalf, and lots of nods, so you know what I'm talking about. Yeah, and again, we're not using faxes or posts anymore, so information governance will be really important as well. So in Newcastle, they found that readmission rates were 3 times less than for patients who had this service than those who didn't, so that's great. And projected savings across Cheshire and Mersey are that you know, potentially we could save 5,000 bed days across Cheshire and Mersey if we can extrapolate those findings across all the hospitals and patients in our area. So that's really, really important. So what we said to the pharmacist at the moment is that all patients should be considered for referral, but it's probably overkill to refer everybody. You know, if someone's coming in for a minor operation, medicines aren't changing, then you probably don't need to know that, and it's just noise in the system. So we are picking who we're referring to start with, at least. But if patients can't give consent or won't give consent, then we don't refer them. If they have their medicines dispensed by a GP surgery, dispensing doctors, we don't refer them. Welsh patients, one of the joys of working in a border town is that you have to deal with 2 systems, 2 healthcare systems, and 2 sets of policies and that kind of thing. And then we're only referring to pharmacies in the Cheshire and Mersey area because they're the only ones we have in our system that we know have the right information governance arrangements in place. So we've been quite tight about that. And there are tons of reasons why we might refer people to you. Adherence problems, so you talk to the patient and say, just take your medicines every day, and they say, oh yeah, yeah. And you look at the labels and they're all 3 or 4 months old, and you think, something's not quite right here. They've got a compliance aid, or they need one. They might need a flu vaccination. They can't manage packaging, they've got swallowing difficulties, so you've had to give them specials or treat the medicines slightly differently so they can swallow them. Unlicensed medicines I know are very difficult to source sometimes, so that's something that might be helpful as well. And stopping smoking as well, that's something else we might refer for. So lots of different reasons. I won't labour this point, but consent is really important, and we do ask that it's always documented in the pharmacy care plan in our electronic patient record, so yeah. So you don't receive the e-discharge letter, which has more clinical details in terms of diagnosis and the course of treatment and that sort of thing. We pull all the information from the electronic prescribing system. Some of the information doesn't pull across, so things like clinical indication for antibiotics doesn't pull across, or where drugs have PRN indications, we always insist that there's a reason for that, so PRN pain or PRN chest pain or PRN dry eyes and that kind of thing. That doesn't pull across, unfortunately, but hopefully once you get the information, if you've got queries, then there'll be a point of contact to come back to and we can clarify that. The other thing about coming into hospital is the start and stop date of medicines starts when it's logged onto the system, not when the patient actually started taking it, and they're often 2 different things, so that information doesn't come across either. But in the dose instructions field, in the transfer of care document, there might be information about that, so I don't do ward work anymore, so I'm going to struggle for an example, but if there's a medicine where you start it and take it for a year, I think ticagrelor springs to mind, that could be wrong, then there'll be a date when it started and when it should stop, so that will help you ensure the patient gets the right care. So the process is very quick, I'll just whip through it. Patients can be selected at any point in their stay. There's a referral lookup, so there's just a list of things that you've seen already. We obtain consent from the patient and fill in those 3 boxes. Again, it's very straightforward. If the patient doesn't give consent, we have to record that and why. And then we record that we've referred the patient through the system. And at discharge, when the discharge prescription prints out, there's a banner that prints on it, so the pharmacist looking after that discharge prescription will know there's a referral being made, and at that point they should check that all the information that's required is coming through to you, and that anything that needs clarifying will be clarified in that document. So it's a very, very quick and easy process for us to follow, which is great.